Hello, I'm Dr. Andrew Yen, Assistant Chief of Gastroenterology for the VA Northern California Healthcare System, based out of the Sacramento VA, and Assistant Clinical Professor of Medicine at UC Davis Medical Center. I'm here today to talk about our recent publication, a novel method with significant impact on adenoma detection, combined water exchange and cap-assisted colonoscopy. Colonoscopy plays an important and central role in current colorectal cancer screening and prevention programs. But as a screening tool, colonoscopy is still imperfect. The reasons for this are likely multifactorial, and some factors, such as tumor and polyp biology, are out of the control of the endoscopist. But other factors are more operator dependent. Therefore, methods that help endoscopists enhance polyp and adenoma detection are desirable. Adjunct techniques to improve the performance of colonoscopy have been an area of ongoing interest and investigation. In this study, we compared conventional air insufflation colonoscopy with the simple, novel technique of combined water exchange and cap-assisted colonoscopy to determine the effects of this new technique on adenoma and polyp detection. Conventional colonoscopy relies on the judicious use of air insufflation to distend the colon until the cecum is reached. Water is used only if poor bowel preparation is encountered. Air is then used to adequately distend the colon to facilitate inspection of the mucosa. The combined approach utilizes water exchange along with a distal cap mounted at the tip of the scope. The technique is simple and straightforward. A disposable, transparent distal attachment is fitted to the tip of the colonoscope. With the air pump turned off, the scope is inserted into the rectum. Residual air and fluid are immediately suctioned out of the colon, and warm water is infused with a paddle pump using the sidearm adapter connected to the scope channel. Infused water is removed by suction predominantly during scope insertion. This helps to minimally distend the lumen for visualization. The scope is advanced, and in each colonic segment, water exchange is performed. Residual air and debris are suctioned, and sterile water is infused. Suction and infusion are performed simultaneously, and this exchange is continued until all turbid residue is replaced by clear fluid. There is no limit to the amount of water used. This process facilitates scope passage with minimal distension and lengthening of the colon. It also provides salvage cleansing of any residual stool. After identification of the appendiceal orifice or terminal ileum underwater, remaining fluid is suctioned and air insufflated to facilitate inspection of the colon. On scope withdrawal, the transparent cap is used to assist with mucosal inspection, helping to flatten haustral folds and improve mucosal exposure. The cap can also provide assistance with any necessary interventions, such as polypectomy or mucosectomy. The concurrent use of these two simple methods has many theoretical and practical advantages. The most significant advantage is the observation that the strengths of each individual technique address the limitations of the other. For instance, potential disadvantages of the water method, such as decreased intention to treat cecal intubation success and increased cecal intubation time, are addressed with the use of the cap, which increases the rigidity of the distal scope and promotes more effective water exchange, which can quickly clear the lumen of turbid fluid and debris. Additionally, concerns surrounding large volumes of retained fluid are addressed as water is infused during the examination is sequentially removed as the scope is advanced, reducing the amount of retained fluid needing clearance during withdrawal of the scope. Furthermore, mucosal suction trauma is limited, even with frequent or continuous suctioning, because the cap at the tip holds the mucosa away from the suction channel. Visual impairment from debris trapped in the hood, a previously reported drawback to cap-assisted colonoscopy, is also addressed, as turbulent flow generated at the tip of the scope by continuous water exchange does not allow debris to settle in the distal attachment. Passage of the cap-mounted scope through segments of severe diverticulosis can be difficult, but concurrent use of water helps open the lumen and straightens the colon, easing passage of the cap-fitted scope. The setup and application of this combined approach is simple. It utilizes equipment readily available in almost every endoscopy unit, and it can be performed without a great deal of added expense or need for specialized training, although there is a learning curve to this technique. In this study, we were able to significantly enhance the detection of adenomas and proximal colon serrated lesions by combining these two simple, complementary techniques. But this approach has the potential to help endoscopists in all phases of colonoscopy: insertion, inspection, and intervention. Larger, prospective studies are necessary to confirm the benefits and generalizability of this technique. Thank you for your attention.